Okay, so the idea now is to talk about myelodysplastic syndrome, which is a quite of precursor of acute myeloid leukemia. It's from the myeloid lineage, so it can affect white blood cells of the granulocyte lineage, uh, platelets, red blood cells, but not the lymphocytes, not B cells, T cells, and NK cells, not them. Usually it affects the white blood cells, the granulocyte white blood cells, or more commonly the erythrocyte lineage, namely the RBCs, and can cause anemia. So it's quite as a precursor of acute myeloid leukemia, and can transform to acute myeloid leukemia. There are subtypes of myelodysplastic syndrome. Some of them have better prognosis, and some of them have worse prognosis. As more blasts accumulate in myelodysplastic syndrome, the prognosis is worse and the transformation for acute myeloid leukemia is more probable. So, myelodysplastic syndrome is a group of disorder that has abnormal cells that develop usually in the bone marrow. It comes from a clonal stem cells, namely from a cell that has become abnormal and start to uh, duplicate itself and create a clonal of cells that are abnormal. They don't function well. That they can look abnormal. So it's a clonal disorder that starts from a stem cells that is abnormal and genetically sometimes genetically mutated, and sometimes there are genetic mutations that can be found. So what are the causes of myelodysplastic syndrome? The cause itself is not fully known, but there are risk factors. Higher age is a risk factor. Cancer using chemotherapy, toxin that can cause damage to the DNA are risk factors. Toxins like, as you can see, benzene, heavy metals, pesticides, genetic factors, Down syndrome. They have very high risk for types of leukemias like ALL and AML, especially megakaryocytic leukemia, as, as the risk is for AML, so they also have the risk for myelodysplastic syndrome that is much higher eh, compared to the general population. Paroxysmal nocturnal hemoglobinuria, which is a disorder that have a genetic PIGA mutation, and there is a problem with the complement system, and there is hemolysis of the blood, and their urine can look quite dark, especially in the morning because of the hemolysis. Never mind, but the idea is that PNH has higher risk for Myelodysplastic syndrome. As you can see here, the symptoms are based on the occupation of the bone marrow and the abnormal malfunctioning cells. So if myelodysplastic syndrome has a clone that proliferate and overcrowd the bone marrow, it doesn't let the other normal cells to develop properly. So there might be anemia because lack of normal RBCs, neutropenia, and bone marrow occupation. So white blood cells can be low, platelets can be low, RBC can be low. Therefore, there can be anemia with pallor or fatigue. There can be thrombocytopenia with bleedings, bleeding for the gum, epistaxis, pathechia, and there can be immune deficiency from white blood cells deficiency. So the evaluation is to take blood count and everything, do a bone marrow examination by biopsy, and look at the bone marrow and see which cells are there and what are the genetic testing that we can see. Sometimes there are genetic abnormalities that we will see that more commonly associated with myelodysplastic syndrome. Now the treatment, you will see that there are some treatments, and some of them are better and some of them, and stem cell transplantation is the only way to cure this, but the stem cell transplantation, as you know, is it's not quite easy and has complication. Now, the prognosis of myelodysplastic syndrome very depends on which group, which subtype of myelodysplastic syndrome we are talking about. There are very bad prognosis myelodysplastic syndrome groups, but there are also the better prognosis, much better prognosis subgroups. Like the worst prognosis myelodysplastic syndrome can have a prognosis median survival of about a 10 months. Now, better prognosis, or maybe the best prognosis MDS, can have a median survival time of about 8 years. So it's very depends on which subtype of myelodysplastic syndrome we are talking about. Now, if we look on myelodysplastic syndrome from McManuel Professional Edition, let's look at what he says. He starts talking and he starts by presenting the different subtypes of myelodysplastic syndrome. We have the refractory anemia with ring sideroblasts, refractory anemia with multiple lineage, refractory anemia with multi-lineage dysplasia and ring sideroblast. So we have some of them that are quite better prognosis, like refractory anemia with low count of blast cells, and we have more blast cells, the prognosis is worse. Like if we're looking at here it is, refractory anemia with excess blast, this has high level of blasts and it can damage cytopenias of two or more cell lines, where some of them is only one cell line that is disordered or damaged. So as more cytopenias, or maybe more importantly, and there are more blasts, it has worse prognosis. Now, as you remember, the definition for acute myeloid leukemia is blast cells 20 more than 20% of blast cells of the nucleated marrow cells. Now, if you can see here, there are also it's also almost can be considered as acute myeloid leukemia. It's from the myeloid lineage, and the blast count is about 90% of the nuclear marrow cells. Therefore, little bit more, and it crosses the 20%, and it can be designed or regarded as acute myeloid leukemia. So you can see the lineage, the connection between myelodysplastic syndrome and acute myeloid leukemia. There are also sometimes genetic or cytogenetic mutations. Remember, cytogenetics talks about chromosomes, genetics talks about, or molecular genetics talks about specific genes. Now, cytogenetics talks about chromosomes. Now, sometimes there is deletion of the long arm of the chromosome of chromosome 5, and is called isolated deletion of the 5q MDS. It's typically have severe anemia thrombocytopenia, but it can have a better prognosis because there is a treatment for this. Here you can see the Philadelphia chromosome, which is characteristic of CML. You can see it also here, fusion of BCR-ABL. Okay, so the symptoms comes from the occupation of the bone marrow, and as we talked about it, deficiency of red blood cells cause anemia, deficiency of thrombocytes cause thrombocytopenia with bleedings, and deficiency of immune cells, especially the granulocyte, cause neutropenia and uh, immune deficiency. So the diagnosis comes from the complete blood count, peripheral and bone marrow examination, and we need to think about other disorders that can cause it. Sometimes myelodysplastic syndrome can present as macrocytic anemia, a refractory macrocytic anemia, and you need to think about other causes of macrocytic anemia, like vitamin B12 deficiency, folate deficiency, and etc. etc. You can see here when his diagnosis is suggested, peripheral blood and bone marrow morphology abnormality in 10 to 20% of cells. Okay. And the red blood cells is the most common link cell line that is damaged. And here you can see associated usually with macrocytosis and anisocytosis. So macrocytosis, the MCV will be high, namely the volume of the red blood cells is high, and anisocytosis, namely the RDW will be high, or the difference in sizes of blood cells is the difference is quite there is a very high difference between the cells. Okay, sometimes also come mutations that are with myeloproliferative disorders. So the treatments, we are treating symptomatic patients usually, not asymptomatic patients, and sometimes need transfusions. But remember that transfusions can cause iron uh, accumulation, what is called secondary iron overload or uh, acquired hemochromatosis from transfusion, however you want to call it. The patient has too much iron and therefore he needs iron chelation to uh, otherwise it can have iron damage in like tissue that are very sensitive to iron, like the heart and the liver. Okay, yeah, now you can see erythrocyte stimulating agents which stimulates the RBCs to mature and develop. GCSF which cause the neutrophil to mature, and the combination of ESA plus GCSF can be a good treatment to help with maturation of the cells, but it's not improve survival, and it doesn't reduce the risk for transformation to AML. Loose patents can be successful in increasing hematocrit in patients with very low to intermediate risk MDS. Okay. Those are the drugs that can be used to treat MDS. They are nucleoside analogs, namely they inhibit the elongation of DNA and inhibit enzymes, and by that they can work on MDS and try to kill or prevent the development of abnormal cells. They can also cause a hypomethylation of DNA. Sometimes in MDS, genes that are important for DNA repair are hypermethylated and therefore silenced. Therefore, reducing this hypermethylation by hypomethylated DNA can help tumor suppressor genes to start to play a role and start to work. Now, lenalidomide can be used in patients with the subtypes of MDS with deletion in 5q chromosome and 5q syndrome, deletion of 5q, and it can help them need less and less transfusions. Okay. Allogeneic stem cell transplantation is the only way to cure MDS, and usually tried in fit young patient. Remember that allogeneic hematopoietic stem cell transplantation is not a very easy procedure. Number, the prognosis depends on the cytogenetics, which abnormalities and how many abnormalities. Blasts, as we have more blasts, particularly more than 10%, the prognosis is worse. Degree of cytopenias, as we have more and more cytopenias which are worse, the prognosis is worse. You can see here the cytopenia that correlates to worse prognosis, which is hemoglobin under 8 gram per deciliter, platelets beneath 50,000, and absolute neutrophil count of less than 800 per microliter. Okay, so here you can see how much the prognosis for MDS can be varied. Depends on the subtype of MDS the patient has. It can go from about 10 months in the worst prognosis, median survival, to 8 years median survival in the better prognosis, in the lower risk group. Okay, so this was about MDS, myelodysplastic syndrome, myelodysplasia, where there is a clonal expansion of abnormal malfunction in cells in the bone marrow, which can cause the symptoms of cytopenias. There are subtypes of MDS, some of them better, some of them worse. When there are a higher number of blasts, the prognosis usually is worse. And it can transform to acute myeloid leukemia. And that's it. Thank you very much. If there are any mistakes, please correct me. That was about myelodysplastic syndrome from Merck Manual Professional Edition. Thank you very much, and that's it.